The CALS course was one of the first educational resources designed specifically for rural ED providers. The founders, Dr. Daryl Carter, a family medicine physician practicing rural emergency medicine, and Dr. Ernie Reese, an emergency medicine residency faculty, recognized the unique set of skills an emergency medicine team needed to manage critically ill and injured patients in the acute setting. Let's learn more about the CALS organization by joining a discussion with their current director, Ann Gill. Welcome to this EMCT podcast, another in our series on onboarding in emergency medicine. Today we have a guest from the CALS organization that helps support rural emergency departments. I want to welcome Ann Gill, their director. Hello, Ann.
Hi, good afternoon. Nice to meet you. And I'm very pleased to be able to talk with you a little bit about the CALS program today.
Yeah, we've had some discussion over the years on how to improve care and support our providers there. But tell us what CALS is, how it started, why does CALS exist?
Yeah, the CALS program really started actually out of a little bit of a necessity in 1996. It was a physician in rural Minnesota that was practicing and noticing and taking all of the advanced life support courses, but they didn't always meet his needs and fit what he needed as a practitioner in a rural setting. And so what happened is he had some conversations with other physicians from trauma centers, and a grassroots really effort then started in looking at what is rural emergency medicine educational needs and how can we make things a little bit different and more fitting for those providers that are in a rural setting that don't always have all the resources that are available to level 1 and level 2 trauma centers.
Yeah, and in those low volume emergency departments, they were staffed by their local family physicians commonly, or whatever physicians were on staff at those hospitals, whether they had an internist or they had a general surgeon. And they all had skills through their residency in particular areas, but didn't have the complete skills of being an emergency physician and provider to see comprehensively. So Daryl Carter is the person we're alluding to, a family physician, and he went to Ernie Reese at Hennepin County Medical Center in Minneapolis to discuss this. And I had taken a course from Ernie. He did resuscitative skills. I spent a little time at Hennepin County myself, and Ernie put on labs for doing particular skills for emergency physicians. And it sounds like he felt like, yeah, we need to have skills labs not only for people trained in emergency medicine, but these providers in rural communities need to have these skills as well. And it sounds like they put something together that was more robust than your typical ACLS and ATLS class. What did they create?
Yeah, really, they created a curriculum that was much more comprehensive and focused, which is really what is seen in a rural setting. These are situations that don't happen very frequently, but when they do, it's crucial that somebody can address that life-threatening event and stabilize that patient so that there's time to be able to transport that patient then, to additional care. And it, particularly in rural areas, this distance can be, quite impressive at times. Weather can be a factor. Distance, of course, can be a factor, just plain geography.
Yeah. So stabilization doesn't mean just stable in the ER until they can get a 3-minute transfer down to the operating room. We're talking stabilizing so they can have an hour or more transport, and whether they go by fixed wing or a helicopter or by ground. So I imagine all of those things have to come up in scenarios that you go through in CALS, huh?
That's correct. And not only some of those basic skills to promote the resuscitation of the patient, but there's also other resources that are limited in those settings, and that includes personnel. You mentioned too, going to the operating room. Well, you might not have an operating room. You might not have the specialization that you need. And virtually most of all of the other advanced life support courses do allude to that next step of getting to that specialization. But that you have that delay of time when you're talking in a rural setting.
Yeah. So some of the other considerations, though, as you mentioned, are the people on your team. So CALS focuses not just on what you need to do as a provider, but how you work with your team. Is that right?
That's correct. And team focus has really been a part of CALS since its inception. Many of the other courses do offer training with how do you build your team, but we've always focused with that. And that includes anybody who's part of that emergency response team, from EMS to the nursing staff, advanced practice, as well as the physician that may not actually always be there immediately when that patient arrives. And so all of those team members need to be on the same page, need to know and respect what each other's roles are and what they bring to the setting when there's a crisis or a crucial event.
Yeah. So I imagine early on, well, you weren't there in 1996, I guess.
I was practicing, but yeah. No, I wasn't during the inception of the CALS program. However, they did take a very methodical look at all of the advanced life support courses and what they offer, and pulled all of those key core components together and developed a curriculum for the CALS program at that time. And really, it was to really identify what do you need to do to rapidly evaluate and stabilize when you don't always necessarily know what the diagnosis is, but to treat those life-threatening events that are there, but then to prepare for transport and initiate that next step. And of course, airway management is a big factor of this, and that was an early focus of the program, is really looking at how airway management is handled and how to develop those skills with personnel that may not have a lot of experience or opportunity to experience that skill on a frequent basis.
Yeah. And the intended audience or target student, I guess, or trainee was the physician initially. Is that right?
It was. However, there were other, it was the entire emergency medicine team that was a part of the focus, including the nursing staff, as well as they have come along with the advanced practice as that role has developed over the years.
Yeah.
EMS has been probably added more recently than the other skills, because we're seeing EMS personnel now more participatory within the emergency setting, in the emergency room setting in the hospital. So this was initially focused for the emergency room, but it has expanded beyond that into the initial scene where the accident or the medical emergency has occurred.
Yeah. So I imagine, yeah, there has had to be a bit of an evolution in in the program, in the curriculum as well, since I imagine, initially the training was probably exclusively or mostly physicians. How has your demographic changed as far as people attending the CALS conference? The nurses are still coming, and there's still a team-based approach. You have the providers as well as the nurses come to practice these skills and scenarios, right?
Right, that's true. Yeah, and certainly we're seeing more nurse practitioners attend the course as their roles have become even more acute care focused, and certainly the physician assistant role too as well.
Yeah. So does that change kind of the approach, or is the philosophy essentially the same?
No, the philosophy has really stayed the same. We do teach skills that may be beyond a specific role's scope of practice. Everybody is exposed to that because we feel that um, you may not be practicing that particular skill within your scope of practice, but you would be assisting with that role. And by working together as a team, working side by side as a with your team that you work with on a day-to-day basis actually enhances your ability to be able to assist the provider then with that skill. And so it's been important all along that those core skills, no matter what the role is or the scope is that everyone has that exposure to it and understands what their role is in that process.
Yeah. Well, in low volume rural facilities, you're going to see less patients by definition, but the acuity in percentages are pretty similar. So inevitably, if you work there long enough, you're going to see some sick people, and you're going to see them in situations that you may be the only provider and you may have some inexperienced staff with you. So it does require that you have proper onboarding. And that's kind of the theme of this podcast series, is really the importance of the onboarding and the education that's available, and the importance of taking all that in and having the skills that you're talking about, even though that may not be part of a regular practice that you do. Unfortunately, you may be called upon to do something like that, one of these skills. And it may be as simple as putting in a chest tube, or it may be something much more complex. And to address that, ASAP has looked at this issue as well, and tried to increase the number of emergency physicians in rural, but that's been slow to occur despite a lot of, a large increase in number of emergency medicine residency slots. More recently, there's been a new initiative for physician-led teams and physician supervision. And that would have to be in the form of tele-emergency medicine. And so we've talked about that topic on this podcast series on a couple of occasions. The Mayo system does this. The Avell system offers that product. And so do a lot of other tele-emergency systems across the country. But that is one way that we may be able to gain parity in quality of care with higher volume facilities, is through tele-emergency medicine and those physician-led teams. Is that something that's on the horizon, or something that is incorporated already in the CALS curriculum, is how to incorporate that communication with a tele-emergency physician?
Yeah, we actually organically incorporate that in within our scenarios. It is a definite advantage, I think, to have that resource of telemedicine. There's also a little bit of a time element of being able to push that button to gain access to your resource with that. And that's where some of the life-saving skills might be necessitated to be started. But it also, the CALS program helps also to build the confidence in performing some of those skills. So even though you may have someone who's walking you through a procedure, it's much easier if you've experienced that in your training and know what steps to anticipate, and have some of that confidence beside you as you have some of that guidance that comes along with the telemedicine. So, it's really a in tandem process, I think, and it's a definite advantage to be able to have that resource right at your fingertips or at your end of other side of your phone or video.
Yeah.
Whereas, 25 years ago, you didn't necessarily always have that. And so it's really helped, I think, in a lot of different rural settings.
Sure. So besides rural, what else does CALS do? You have some other organizations you work with, and you work with some U.S. embassies and things as well?
We do. And just a little bit of that history is we started to provide education with first initially within the state of Minnesota. Other people had heard about the program, and it basically just grew by word of mouth from person to person. And so we started to have other people from other states. And eventually we had some contact with the US Embassy staff. It's physicians, nurse practitioners, physician assistants that provide care to the Department of Staff in a embassy that could be in a very remote area. And they needed some training with emergency medicine, and the process that we have been doing all along for rural areas really fit well with what their needs were too as well. So we do provide initial orientation for that group of providers that do serve it in that capacity. We've also worked with groups in other countries, particularly residency programs in Haiti and Kenya, but also we've also worked with another group of providers that provide medical services and transport services for people who are immigrating to other parts of the world, and that's the International Organization of Migration, and they're with the United Nations. And they had a need also for some emergency training. And the CALS program, really, the core principles have been applicable to all sorts of different settings like this.
Yeah. So if someone in another state wanted to have a CALS course, what's that process? How does CALS get funded in Minnesota? And do other states have to find that funding through legislative action, or what would it take to bring CALS to another state?
Yeah, so we do work with other states, and I would say that every state is approached a little bit differently, oftentimes because funding for rural medicine can be unique depending on how the state is handled with their legislative processes. In the state of Minnesota, we're heavily funded through legislation efforts, and which is a tremendous benefit that we have to be able to provide this service at a lower cost for providers and healthcare professionals dealing with emergency medicine in the state of Minnesota. In other states, they do tap into some of their rural health groups that do provide some services, or even their trauma services have also looked towards CALS to be able to provide some of their needs for education related to trauma service skills. And so it's really dependent from state to state on how it's approached. And there's not a real, I would say, cookie cutter way for a CALS program to become initiated within the state, other than to know what the resources are for rural emergency medicine education and tap into some of those opportunities.
Yeah. So if someone wanted to start it in their state as a state organization, or if it was a state ACEP organization, they could contact you at CALS and try and get some details on that and what it would take to bring a course there.
That's right. And we can walk them through different things that different states have utilized. There's different approaches, and they can start by exploring what opportunities that might produce for them.
Yeah. Yeah, good. So where do you see CALS going in the future? Are there any changes that are happening? And again, I guess we alluded to the preponderance of PAs and NPs that are requiring this training. There are more and more of them going into lower volume critical access hospitals in Minnesota and through the Midwest. Our critical access hospitals are a little smaller volume than they are out east, where they might be 30,000 or more. We're talking 3,000 or less on annual volumes. So quite a bit different that, from state to state on what really defines rural and what really defines critical access. So with more and more the PAs and NPs taking the course, is there anything that's changing within CALS?
Yeah, one of the things that we've identified, particularly with nurse practitioners and with PAs that are fairly new entry into the healthcare system, is there there may be a need for additional exposure to some of the airway management skills. And so we have developed and are launching a module that is really just focused in on airway management. And to begin with, particularly with those providers that haven't had previous experience at all. Now, this is an introductory course, and it would lead right into then what you would also learn at a CALS course. But it really, hones down on some of the basics on, how do you hold the equipment, and how do you, some of the cues, and how do you manipulate that type of skill to be able to then go on to the next level where you can really focus in on the difficult airway or those types of additional skills. There are other areas too. We know of the challenges with care for and mortality, high mortality for women in OB in rural settings. And so we also have a module that focuses simply on that, where it's those emergency events that could occur in a rural setting, and sometimes there's no resources for very many miles for them to transport a patient. It's just too long. That baby's going to come, or that emergency is going to happen. And so we've focused in on that skill too as well. And that's particularly helpful for these rural hospitals that may not have rural OB care anymore.
Yeah. Oh, I think that's one of the more frightening areas for any provider that works rural. It's always on my mind is, I mean, a simple delivery or common things being common. Yeah, that's what happens most of the time. But without an obstetrician backing you up and being able to perform C-section when that's necessary, or having a difficult delivery or breach, oh my gosh, yeah, those
Or the
are
bleeding complications.
right.
Yeah, there's it's really not designed to be a replacement for additional advanced life support courses that really focus in on this, but this is for really those emergency medicine personnel that
Yeah.
may be faced with that don't have an expertise in that area.
Right, right. No, very valuable. No, for sure. So, so what else about CALS? Anything else you want to give us information on, or? Yeah.
Yeah, I think, we're also very aware of how long we pull people away from the bedside for education. And so we've done some changes with our core education. And we've always had a component of home study before you attend the course, with the advantages, I think, of internet access in so many different rural areas. And pretty much you can get anything on your cell phone now. We do have that component to help guide that gaining of your basic knowledge before you even come to a CALS course. That's always been an expectation. And now we've been able to utilize and tap into some of the technology that has been rapidly developing over the last 10 years or so, and actually be able to access people in, quite remote areas quite easily with some of that education. So we look forward to being able to do a little bit more of that. But really our core method of teaching is hands-on. And this is something that we don't want to stray too far from. That's the core advantage of the course, and what everybody tells us that they enjoy so much is really that hands-on learning the skills and hands-on working through a scenario in a difficult situation. And that's best done in person. And we're going to keep that core component of the course, even though we have some advantages with technology to augment that.
Mm-hmm. So beyond advanced life support education, are there other components of education? I mean, there's a lot to being prepared to be an emergency provider. Are there some lesser acute educational modules or or educational content that you're looking to add, or what are you looking at in CALS
Yeah,
going
we've
forward?
considered that because there's a whole host of other emergency skills or skills that you encounter in an emergency setting that, needs additional resourcing. And so we've explored that with different programs and are considering how that we could translate some of those skills also and blend in with what we've always kept to be our core, which is really
Advanced life support.
resuscitation. Yeah.
Yeah, well, there's a lot to onboarding, and CALS is certainly a component of that. There isn't any one piece that makes you an emergency provider. It really takes a whole host of programs and really a lot of hands-on educational experience. Hopefully, providers can get that at a high volume facility, but we're seeing less and less of that, or that's becoming more and more common, that the first job is going to a rural setting, and that's unfortunate. So all the more importance that we have educational programs like CALS and others, where they get a mix of different educational experiences and get a sense of the broad scope of emergency medicine that's necessary to be able to practice safely and competently and confidently.
Yeah, and I think that's one thing that I have really watched over the years with people going through the CALS program. So you have somebody who is a pretty new practitioner traveling through the CALS program initially, and what they get out of the program that first time is different the next time that they take it,
Right.
because the program does allow for and actually promotes people with different levels and experiences to be training at the same time. So we can be inspiring for that very new practitioner, as well as that practitioner that may have been practicing for 30 years. And that's where I think some of the magic happens in the course, is when you see that transfer of knowledge between the different roles, in not just roles, but also experience levels. And I think the program has the depth that it can manage that between the different levels of experiences. And there's not very many programs that, can tap into that, where you take the course, subsequently in another time, and it speaks to you in a little different way, or you pull
Yeah.
different information from it.
Well, I imagine you have nursing staff in EDs that have been there for years, and then they have a new provider that comes as their team lead. And I imagine there's a lot of education that has to come from the nurses to that provider to let them know how to organize and most efficiently manage critically ill patients as well in those settings.
Oh, certainly. And I think even since the pandemic, we've seen where we have different nursing groups move in to a particular rural setting that may not have been there before. So that's one of the things that is core with all of the education all the way through the course, is really how do you rapidly establish your team, and how do you, understand what each person's role is and what each person's duty is then when you do have that emergency. And I think that's one of the biggest things, Steve, that we do see, is that need to be able to rapidly readjust to your team that you have that particular day is really what's crucial. Years ago, we had a fairly stable team, and what we're seeing now, with a fair amount of movement within the healthcare systems now, particularly in rural settings, is that need to quickly establish a new team depending on the day and who you have working with you.
Yeah. A big part of working rurally is knowing your team, as the provider. If you're a locum, or if you're just not part of that community normally, if that's not a place you regularly work at, you lean on those nurses that work there to let you know, how do you transfer someone? What are the resources? Sometimes you have to go by air because, you may have only one ambulance that's in your area that can respond to 911 calls otherwise. So we wonder at high volume facilities when we get the referrals in, well, why did this person come by air? Well, there just wasn't another option that we get this patient in a timely manner without devastating the EMS in the particular area, their response. But yeah, knowing your team, knowing the resources for the community, those are all a big part of I'm sure going through these scenarios, and part of the educational process of bringing that team together at a CALS course and really playing out those scenarios, in practice before you have to do them for real.
Yeah. And we do really encourage that when people attend the course, that they attend as a team, at least 3 or 4 people from the particular facility attend together. That's when it's most effective.
Yeah, yeah. Now, do you do some courses right at the facilities, right at the hospitals, or is that where most of them are, or do they come to another central location for a majority of your courses?
We have both, and it depends on the area, but the majority of times we do go to whatever facility is needing training. We'll go to that facility, and oftentimes there may be surrounding facilities that also then send their personnel to the training at the same time. Typically, we have a course that it has about 24 people in the course is our ideal course size. So, in a rural setting, it's pretty hard to pull 24 people away from the bedside at one facility at one time. So we usually have several different hospitals go in together in that surrounding area, attend the course. We do have centralized areas too, and it just depends on the location and preferences of what works best.
Sure, sure. So again, if someone wanted to do this in another state, do you have a mobile team that would go and give them an example of a course, and just put something on, and then they can decide if that's something that they want to do on a regular basis?
That's typically the way it's done, is
Okay.
we will come, bring all of the equipment, and we will coordinate the course at that location. Oftentimes those initial courses in another state, the attendees are likely people who are leaders within education of that state already, and they attend the course. After that, then we can talk about how to potentially transition some of those people into becoming instructors and being able to set up their program within their state.
Right, right. Well, cool. Well, what a great initiative that was started back in the 90s to help support rural EM providers. Emergency medicine as a specialty was well launched, by the mid 90s, but the care in the rural setting was still lagging. It was, decades behind on getting quality educated physicians and then APPs in that setting. So we're still in the process, I think, of evolving and getting a standard of training and education for rural EM providers. But that's what this podcast series is about, is what are the resources that are available now, and where do we see this going into the future as a standard in education, so we can bring parity of quality care to rural as compared to what we get in the urban counterparts now, or do as best we can with limited resources. So I appreciate you coming on and explaining the CALS program and another one of those resources that are available, Ann. Thank you.
Well, thank you.